Hi, folks. Guess what time it is? Straight up 4 o'clock in the mountains, which means 6 o'clock on the East Coast, 3 o'clock on the West Coast, and 5 p.m. in the Central Time. And it is time for Fertility with Fink and Friends. I am Fink. You are friends, and good afternoon. It's Tuesday, like it always is when we get together here. And it's such a pleasure to see everybody. Gosh, folks are just joining right in here. First one here on the CNY side is Lily Provenzo. Lily, thank you for being number one in my day here on CNY. And over here on the other side, Nancy Bernard from Miami, and Mandy are my first people, as well as my other friends there, Mr. Mortgage Man in Miami. Got all the Miami friends here today on the Facebook side. So we've got Facebook and YouTube and LinkedIn over here on this side, and a couple of different Instagram feeds. And sure is nice to see you all on this Tuesday afternoon. Hey, how's it going? How's everything? How's everybody feeling out there? It's another beautiful day here in Colorado, so I am a place to be monitored if you're doing some fertility treatment. I would say it has been a great week. Hi to Allie, of course, who has joined, and hello, Brandis. I'm happy to say that my friend Dr. Faruqi is coming to town here to give me a couple days off in the next couple of days. So if you happen to be by the Colorado office, you'll see him working diligently with Brandis. We have been talking and been thinking about, kind of what makes this whole thing. As you know, the whole fertility journey is such a roller coaster. It's an up and down. I say it's the crappiest roller coaster in the park, because before you know it, it flips you over and turns you around, and my thing is flickering here. I'm not really sure what that's all about. That was strange. I was doing some funny things there on the CNY Instagram side. This roller coaster, it flicks you upside down, it jams your head to the side and gives you a concussion, makes you barf, makes you sick, makes you really the crappiest roller coaster in the park. And were it not for the fact that you had to be on it, you probably wouldn't choose to be on it, And so given the nature of that very unpleasant roller coaster, is there an upside to it? And I would say absolutely there's an upside to it. And from our perspective, it hurts us every time that we hear someone has gone through treatment and has not gotten pregnant. IVF is really a numbers game. It's really about maximizing the opportunity to make the most number of eggs in order to make the most number of embryos in order to give you the most number of options. And in most cases, we can speak pretty intelligently about what the odds are and about how we can confront those odds. But handling a group of numbers is not the same thing as having to ride that roller coaster and getting whiplash from the way it turns you around the corner there. The thing that makes it worthwhile, I think, and I was talking about this with my friend and colleague Brandis, are things like, I don't have, there we go. Here's one. Things like this. This is Charlotte at 11 weeks. It's when we get those cards and when we can, put them up on our bulletin boards and really can know that what we have done. No sound? Okay, tell you what. How about that? Is that better? There was no sound over on that side, so maybe now it's a little bit better. No sound. Everybody's telling me no sound. Can't hear me. Okay, can you hear me now? Hopefully you can hear now on that CNY side. Yes, fingers, thumbs up. So what I started to say, better. So maybe there's no sound on this one too. I'll tell you what, let's pull that out. Maybe now you can hear me better. All right. Well, so what I was trying to say before I got so rudely interrupted by the audio problem there was that it's little things like that. It's about that kind of picture. Um, it's about getting those pictures. It's about seeing that we can actually help people and that people are able to achieve a family. And that's what makes riding this very crappy roller coaster kind of worthwhile. So what I started talking about over here, to those of you who are just able to hear me, is what an unpleasant roller coaster it is to have to be on this. Looks like Facebook could hear me, but maybe it was a little Instagram problem there. So anyway, thanks for being here, as always, on a Tuesday afternoon. So let's jump right into some questions here and see what we can come up with. Kirsten's asking, will there be a part of the summer sale where we can purchase individual FETs apart from a full cycle? Very good question, my friend. I honestly have nothing to do with the finance side of things, but I do know that there is a special sale going on now for the summer, a little discount on the IVF side of things. And I will say, while having to do a frozen embryo transfer can be a drag, the fresh transfer is included in the price of IVF. So having to pay extra for FET, I know adds up. But what I really want to point out is that, gosh, it's so nice to be able to offer frozen embryo transfers at the price point that CNY does, because many places it's $7,500, for a single frozen embryo transfer, and honestly, that's just unconscionable. And what I go back to every time, in addition to being able to get these. I got to show it again because it's still here. Charlotte at 11 weeks. In addition to getting these little pictures, and I'll tell you, I wish I could walk you across the hall to Brandis's office, because she's got this beautiful bulletin board of all the pictures that people have sent her, and that's what keeps us going. And honestly, I know for those of you who are riding this crappy roller coaster, that you really wish you can get off. And what I want to tell you is that there is a light at the end of this tunnel, that we know where this train is going to pull into the station. And God willing, if you have the courage, we can get off the roller coaster with a little extra something that we didn't get on it with, and maybe that's a baby. So I always say it's kind of fun to come back here to leave from Colorado when you're visiting with a lovely parting gift, and that parting gift wants to go to college. And that is in our prayers, really, for all of you. So jumping back to the questions over there on the Facebook side. Thank you, Sharika, for telling me that you can hear me. And Pretty Girl Welch, yep, it is an unpleasant roller coaster, to say the least. I just received, BJ Pumping would like to know, when do I start the Metro meds? I just received my CVS specialty meds. So everybody can get their meds from different places. If you're getting yours from the CVS specialty pharmacy, then that has to do with your insurance. And so for those people who have to pay out of pocket for medication, CNY tries to get you medications at a discount. And so we use some fertility pharmacies that offer very good discounted prices based on the volume of patients that CNY has and refers to them. So they're generally able to give us some very good pricing there. But sometimes, and Metro Drugs is one of them. Sometimes it really depends. If your insurance tells us it has to go someplace else, we will send those prescriptions into wherever seems to be the lowest cost. All right, let's see what we have. And thank you, says Tiffany, for making IVF affordable. Thank you for being a part of our program. All right, let's see what else we have here. Zymot, when is it necessary? And this comes from, it looks like Your Delight, which is a very nice name. Zymot is a method of selecting sperm. Zymot can be used for IUI, or intrauterine insemination, where it is really what amounts to what's called a swim-up method. And that's where we place the sperm inside. It's a little cartridge. And in theory, the best and the strongest swimmers are able to make it all the way up to the other end, and that which comes out from the other end are supposed to be the best sperm. So certainly for IUI, that is a process that would otherwise take place in the laboratory. Many practices will use a Zymot device for IUIs. Because, in a general OBGYN office, for instance, because it it makes the process easier. There used to be some laboratory kind of kits that a general OBGYN office could buy that would help to separate out the best and the strongest sperm so that that practices could do IUIs without having to resort to going to a fertility clinic that requires really a full andrology laboratory like we have. So Zymot is it's available for IUI. In our clinic or in our laboratory, since we have a full service laboratory at CNY or really any fertility practice, I'm not sure that Zymot is a cost-effective device because it gets expensive to use that. We use it sometimes with IVF. And why is that? Because, again, it can help to select some of the best sperm that's otherwise left to the andrologist or the embryologist to be looking under the microscope to personally select, to hand select which sperm will be used to fertilize the eggs. Zymot kind of does that for us. And then you can sort of, it just decreases the size of the pool of sperm that's available. By the way, did you see my Instagram post, some 5 fun-filled facts about sperm? Did you know, if you didn't see it, you should look at it. It's on my Instagram. And I think it's on CNY as well. Did you know 1,500 sperm per second, 1,500 per second are what the body produces, which is really, pretty amazing stuff. Pretty amazing there. So that's really the purpose of Zymot. Zymot is also supposed to be used in situations where there may have been problems fertilizing an egg. But what we know is that, in fact, it does decrease miscarriage rate because it overall decreases pregnancy rate. Now you're saying, well, wait a minute, if it's decreasing the pregnancy rate, I want to get pregnant. Why would I want to use something that's going to decrease the pregnancy rate? Well, because if it's selecting out better sperm that are better able to fertilize an egg, then you could make the argument that maybe what it's doing is helping to select out sperm that are not, or that, that might not otherwise be able to fertilize an egg, that those sperm are excluded or somehow or another aren't being used for fertilization. So overall, the number of pregnancies decrease, but as a result, the miscarriage rate decreases. So I think that there's definitely a place for it in those who have recurrent pregnancy loss. Megan Downey is asking, what are the reasons doctors suggest IVF for low AMH instead of just trying to conceive naturally? Well, I would tell you that conceiving naturally is probably a pretty good idea if it'll work. Really, the thinking there is that when you have a lower ovarian reserve, and we do the blood test, that AMH that shows a lower ovarian reserve, what it tells us is that the clock's ticking. And if the clock is ticking, then we want to get you pregnant as soon as we can. So home intercourse or timed intercourse at home confers a pregnancy rate of about 1 to 2% per cycle. And a cycle is a month or, kind of a normal menstrual cycle, 1 to 2% per cycle. Whereas when we do IVF, we can offer you a pregnancy rate of up to 60% per embryo. So dramatically higher success rate, the time to pregnancy and the efficiency of the process, the effectiveness of the intervention is going to be the highest with IVF. So that's the reason that we kind of go looking for, we might say IVF is a great option. Let's just jump on it because the clock's ticking. How much time are you going to spend doing it on your own? You should definitely do it on your own. You don't obviously want to just walk in and say, I'm going to have IVF because we haven't ever tried before. We would tell you, well, how about you just give it a try? give it a try. Natural pregnancy is always an easier way to go, but hopefully that answers the question there. Gabby is here today. Hi, Gabby. Testing negative day 8 after a day 5 FET. Am I out? Yes, I know I shouldn't have tested at home. Gabby, what's wrong with you? No, day 8, it's usually by day 10, day 11 that we would start to see a pregnancy test being positive. And by day 8, and that would be a beta that we see positive by day 10 to 11. Your urine pregnancy test may not be positive yet because it may be that hormone level is so low that it may not have been enough to trigger the test as positive yet. So no, Gabby, you are not out, and stop doing that. Stop trying to break all the rules, would you? Gee whiz, Hi, Shannon. Nice to see you. I'm on 2 28-day packs of Oralissa before my next transfer. Can I wrap up Oralissa 1 week early on the second pack, or do I need to take the full 2 packs at 28 days? The data on Oralissa for endometriosis suppression prior to doing an embryo transfer tells us that it's 60 days. So, even 2 28-day packs is a little bit less than 60 days, but it's basically 2 months. Could you wrap up a week early? I wouldn't think. Well, it just depends. It depends on how you want to answer that question, because the purist would say the data says 2 months. And so, 7 weeks is not 8 weeks. And so that doesn't do what the data says. I personally find it hard to imagine that 7 weeks is any less preferable to 8 weeks. So I would say, I think in that situation, you're probably okay there, Shannon. Thoughts on Invocell. This comes from Savannah Vaughn. Hi, Savannah. Invocell is a kind of a device that's used where fertilization and embryo culture is performed together in a little cartridge that's placed inside the vagina. And by all rights, that sounds like not a bad idea. It's definitely cheaper than most places offering IVF, but it's still expensive. I do not believe that it confers any advantage over IVF with ICSI or even conventional IVF performed in the lab. If you are in a place where IVF is going to cost you $30,000 to $40,000 for a cycle, or for that matter, even $20,000 for a cycle, something like Invocell might be useful, because it is going to be a cost savings for you, because basically they take the sperm and the egg and they put them together in this little device, and you tuck it in your vagina at body temperature and let it do its thing. I do not think that it is superior to IVF, and there's no evidence to show, really that it is. And when I say IVF, I mean the process of fertilization within the laboratory. So if you're in a place where IVF and the laboratory portion is affordable, like it is at CNY, I would say use what is proven, use what's been known for the last 40 years, rather than something that just kind of sounds cool and may save you some money in a full retail kind of price IVF environment. So let's see. I got a bunch of questions going back up here on the CNY side. Nobody's saying really much of anything on Facebook, so I don't know if anybody's even over there. Bree Noel says, how are you guys able to be so affordable compared to other fertility clinics? The one I just had a consult with quoted me at over $14,000 for IVF. Hey, Bree, I'll tell you what, if you got quoted $14,000 for IVF, that is probably pretty reasonable compared to most of the other ones. The average price of IVF, well, it sort of depends on where you are and so forth, but there are some things that go along with this IVF process, and that, there's lots of little add-ons, there's lots of little tests, there's lots of little ways that many of these practices will try to get you to part with your money. And I mean no disrespect to any other fertility practice, but the way this whole system has been created, it's that it is priced at a premium for people who have this burning desire to be able to have a baby. And so they know that the market will bear it, so they can charge it, and odds are somebody is going to be willing to pay it. So again, not to say that there's anything unethical or anything bad about what any of these other practices are doing, but CNY offers some things, to be honest with you, that I just haven't seen in other places. One of those things is upfront pricing. You know how much it's going to cost. If you look in your portal, when you have your consult, you'll see a document that's called the financial welcome packet. And in that financial welcome packet, all the prices are outlined. Even on the website, you can see what things are going to cost you realistically. I have never seen another fertility practice that publishes the price of their IVF in black and white with all the add-ons, whatever it's going to cost you, right there for you to see, and for you to see without having to have a consult, and for you without having to give your phone number so that somebody calls back and tries to make sure that you come in for an appointment. So all that pricing is upfront. CNY also now has some medication bundles to try to make that easier. CNY offers financing without a credit check, which is unheard of in this industry. But how do we do it at this price point? It's because we see more patients. It's because of the volume. And with that volume, I will be completely honest, comes some things that make some people uncomfortable. And some of that may be things like, well, when you contact our global team, if you're not a local patient and you're being managed by our global team, it may be that we have trouble getting your ultrasound results, or that we have trouble getting your blood test results. So it may take a little extra time, that you can try to reach on the phone and can be very frustrated because it doesn't seem like somebody is answering the phone. Or you can send a portal message and you may not get an answer back for some time, whereas you want to know your answer right now. In a practice where you're paying, $30,000 for IVF, you probably can get an answer a little bit more quickly. But make no mistake, the care is the same. But in this model, for example, we are just able to see more patients, so we are able to offer IVF at a lower price. The IVF you get here at CNY is no different than the full price, we'll call it IVF, that you will get someplace else. I also say that we certainly here in Colorado Springs, and with each of the providers who I've talked with in my company here, the docs in New York, in Syracuse, in Buffalo, in Albany, really pride ourselves on being able to provide one-on-one patient care. When you are in front of us, you are the most important person in the universe. And that's what you should come to expect from your doctor. And that's whether that's your primary care doctor, your OBGYN, your fertility specialist, your surgeon, whatever doctor you have to see, you should be the most important person in their universe at that moment. I want that for myself when I go to the doctor. I want that for my family. And that's the kind of care that you can expect here from us individually at CNY. Oh, what else we got going on here? Gosh, it's nice to see all these folks on the live here. Sorry, we started out with a little bit of some audio problems there. Megan is asking about, and talked a little bit before about a lower AMH, and we talked about why would we talk about going to IVF instead of trying on your own, and I do want to revisit that, Megan, because I think it's important that you do try on your own, but just understand that your body's telling you it's time to be pregnant. Your AMH, you're 32 years old, your AMH is 0.4. So that is a lower than average ovarian reserve, or what we would call a diminished ovarian reserve. What causes that kind of thing? Well, we don't always have an answer. But the current belief is that it may have something to do with the immune system. It may be that you have some sort of autoantibody response against your own ovaries that's causing a more rapid loss of eggs within the ovaries. It may be that you acquired some illness at some point that you maybe weren't even aware of at the time that caused some damage to the ovaries. But what it tells me is that if you'd like to be pregnant, it's a good time to do it because the number's probably not going up dramatically. Now, I will say that there are some supplements that you can use that are said to improve egg quality and ovarian reserve. And again, you know what? Every single live I mention this book because I really do think it's a Bible, and that's that it starts with the egg, which is probably backwards right there for those of you on Instagram. But that book was written by a woman who herself was in her young 30s, Megan, who had diminished ovarian reserve. She, it turns out, was a scientist and sort of poured through the world's research, the world's literature to find out what's the evidence-based approach? What can a handful of vitamins do to help human reproduction? That's what that entire book is about. So I don't want you to think that you are at the end of your reproductive life, because you're not. You're still pretty young. We still have a chance. We can still help. So don't give up there, my friend. Okay, let's see what else. It looks like Bree is saying, oh, yeah, Bree understands 31 with an AMH of 0.3. Been trying for a year. So that situation, Bree, would make me say, all right, if you've been trying for a year, I'm not sure what you've been doing, but if you're trying on your own and a year's gone by and you haven't gotten pregnant, it's time to step it up. Your body's telling you that you want to have a baby. Your heart is telling you you want to have a baby. So these are the kinds of things that we can help you with. Kirsten is telling me that my most recent FET was unsuccessful, and I am sorry to hear about that. I had an HCG wash, but the nurse didn't use the HCG that I brought. Would that cause failure? No. Sometimes we have extra HCG that's here in the office, and so we will use the one that we have so that you're able to keep yours for something else, for HCG boosters or the like, or be able to use it in another cycle. But no, my friend, that should not have made a difference. Although I'm sorry to hear that your FET didn't work. My fingers are crossed, of course, that there is happiness at the end of your rainbow. All right, over to the Facebook side. Tamara Suarez. Hi, nice to see you today. Can you get pregnant naturally while doing an FET donor egg transfer if you are still ovulating and have intercourse when you ovulate? So I think what you mean there is if you're doing a cycle and you're planning to, if you made some embryos with the donor egg and you're doing a natural cycle, frozen embryo transfer. And so in that natural cycle, we want your body to contribute your own hormones to the whole picture, which means that we let you make a follicle, and that follicle has an egg inside of it. And just like every other month, when you're going to have a period, that follicle grows and it makes estrogen. And what does that estrogen do? It builds up the lining of your uterus. And that lining acts as your baby blanket, So then when that follicle, when your ovary releases the egg, and that's ovulation, the estrogen making factory becomes a progesterone making factory, and that progesterone fixes that uterine lining so that you can maintain a pregnancy. So you're asking, during that process, when we are getting ready to, when we start the clock ticking on when you're going to have your transfer by your ovulation, if you have intercourse, can you get pregnant? And the answer is, oh yeah, yes, you can. And it does happen. The more, and is that a terrible thing? No, I don't think that's a terrible thing at all, because the goal here is that you want to be pregnant, right? So I think that's fine. Where things get a little more challenging, and I got this question the other day, that a patient was going to be an egg donor. So she had gotten her stimulation. She had, like 25 follicles or something in her ovaries, and she got her trigger shot. And with that trigger shot, that starts the clock ticking. You get your trigger shot. 35 hours later, we're going to do your egg retrieval. But she, even though instructed not to, got swept up in the magic of passion and had sexual intercourse at home with her partner. So she got about 50 million sperm deposited after she had taken a trigger shot to tell her to ovulate, and sperm can live for 3 to 5 days in the vagina. So in fact, that puts, kind of some big risk there on her for getting pregnant, potentially having multiples. Now, when we do that retrieval, we have given you the trigger shot, but we do not expect that your ovaries will have released the egg. So the egg kind of hangs out inside that little follicle, and it's think of it as like a flower. It's kind of stuck on a little stalk, and it's growing like a little flower. So when we give you the trigger shot, it causes some cellular maturation in the egg there, but it causes the little stalk to go away so that the egg is free floating. Well, if we don't go in with a needle and suck that egg out with your egg retrieval, then eventually what's going to happen is going to be the same thing that happens to you in a natural cycle, that the ovaries are going to act like a squirt gun and go, and they do make that noise actually, and squeeze out that little egg. And that's the process of ovulation. Now, we really don't want you ovulating 25 eggs when there are 50 million sperm in your vagina. Can you do the math and understand why not? That's a bad idea. So that's why we tell you, after you've done your trigger shot, please don't have sexual intercourse. Please don't have sexual intercourse. All right, there we go. So the answer, Tamara, is yes. Yes, you can. KDB is saying starting on an IVF cycle after 2 failed IUIs. Katie has a diagnosis of PCOS. Your AMH is 10. So anything with an AMH that's above about a 5, we think of as being consistent with ovaries that are going to behave like polycystic ovaries. They're going to tend to respond very aggressively. They pay good attention to that medication. How likely is it that I have a good quality eggs for transfer? I've been taking all the supplements for more than 6 months. Well, first of all, my friend Katie, you are the bomb for taking the supplements because it does make a difference. But you're absolutely right that quantity is not quality. So that's why when we see ovaries that are consistent with PCOS, we tend to lower the doses of the medications that we would normally use. So let's say that you're walking in and you're planning on doing IVF. Usually the dose that we're going to use is going to kind of be based on your age, because based on that age, we have an expectation of how you're going to respond. Age number 1, and number 2 is your AMH, that ovarian reserve, the anti-Mullerian hormone number. That's how we come up with dosing for you. With an AMH of 10 and PCOS, again, I'm going to expect that you're probably going to respond pretty well. So rather than giving you the age-appropriate dose, we're probably going to drop the dose a little bit to keep you from getting too overly hyper stimulated. We don't want you to make so many eggs. The data shows us that anything more than about 15 eggs really doesn't improve the outcomes. So I don't need you to get 65 eggs. You may think, oh my God, that would be the greatest thing ever. What are you going to do with 65 eggs, And frankly, if you get 65 eggs, that when you go to fertilize them, you're going to find they are probably not all great quality eggs, because quantity is less important than quality. And the more eggs you make, it tends to be that the quality starts to drop off. So that's a really good question there, KDB. I just like saying KDB too. So that's cool. All right, let's see what else we got going on here. Hey, Nikki Jones is on the broadcast tonight. By the way, it's 35 minutes past the hour. We got about another 25 minutes here on our Tuesday evening Fertility with Fink and Friends. So glad you're all here. Please ask me questions. I'm going to try to get to everything I can. Can't always get to everything. But Morgan Michelle would like to know, what's the main cause of failure with FETs using euploid embryos. It's a frustrating thing. And I got to tell you that it's happened several times this week that I've spoken to folks who did a first euploid embryo transfer. And what that means, if you don't know, when you make embryos, one of the things that we can do is to test those embryos. Testing the embryos is called PGTA, pre-implantation genetic testing for aneuploidy. PGTA. Okay, so what they're doing there is they're biopsying the portion of the embryo that will become the placenta. It is possible that you can have a normal placenta with an abnormal embryo, with an abnormal baby, or vice versa. You can have an abnormal placenta with a normal baby. So it's not a perfect system. And that's why we say that PGT testing is said to give us a 60% probability of a positive pregnancy test and about a 50% probability of an ongoing pregnancy. So the first thing that happens is that they're biopsying the portion of the embryo that becomes the placenta. They're not taking a piece of your baby, because something just doesn't sound right about that. It's what's called the trophectoderm, and it's the outside part of the embryo rather than the inside part, which is called the inner cell mass. So they're taking a portion of the placenta, and there can be some discordance. There can be some disagreement between the chromosomes that are in the placenta versus what's in the baby. So that's the first reason. The second reason is that, well, even though we know that the chromosomes are believed to be normal, it doesn't say anything else about these millions of other little chemical processes that have to take place inside the embryo. That little blastocyst is truly a little functioning machine. And think about it as a train that's riding down the tracks. You know, it's riding down the tracks and everything is great until a screw comes loose somewhere in the, actually, I just want to say caboose. A screw comes loose in your caboose. That sounds nasty. I won't get in trouble for saying that. A screw comes loose in your caboose. Something happens somewhere mechanically in that train, and suddenly that train's not going anywhere no more. The steam comes out, the bell's going ding, 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 and the train just kind of comes to a stop. You ever been on Amtrak? I used to ride Amtrak a lot on the East Coast between Washington, D.C. and New York. And you'd get on it and you'd be like, oh, thank God, we're finally moving. We're finally going someplace. And then it kind of goes, and then it just stops. And then there you sit sometimes for 30 or 40 minutes for no reason, because you can't even see the front of the train. You don't know what's going on. Is there a cow on the track? Did a screw come loose in the caboose? Whatever it may be. Well, same kind of thing. If there is a mechanical problem or a biochemical problem in that embryo, it may not continue growing. So that's the thing. And, those are two probably pretty good reasons. But the other kind of good reason is that, well, to be honest with you, it's not a perfect system. So even if we had some ability to test all those little chemical processes and test the chromosomes, it still wouldn't be a perfect situation, because there may always be some kind of variation in something about the cells, or less frequency in something about mom that keeps that embryo from wanting to take up residence and grow. But usually after a couple of failed euploid transfers, because we think that when we test those embryos and they are said to be chromosomally normal, which means euploid is the term we use, that means normal chromosomes, we expect that you should have 2 euploid embryos for every baby that you would like to have. 2 euploid embryos. So what happens if you do 2 transfers and you're not pregnant? Didn't work. Well, then I start looking at some other things. I start thinking about endometriosis. I start thinking about, is your uterine cavity normal? And when was the last time you had the uterine cavity evaluated? Hysteroscopy or saline sonogram. So we want that to be at least once a year. And we start looking under stones for things, trying to find reasons that might have prevented you from being able to get pregnant. But those are probably the two best reasons there, my friend. So let's see what else we got here. My friend Mandy, who I talked to, just met through Instagram last week. My AMH is 0.9, but the FSH is 5.9. What would that mean in terms of egg quality versus quantity? So in the olden days, Mandy, we would look at a day 3 FSH, and that we would use to have some predictability as to how you may respond to medication. Nowadays, we don't really think about FSH so much anymore because AMH, the anti-Mullerian hormone, is so much more reliable when using it as a predictor for how you will respond to medications. Generally, we think of an AMH of less than 1 as being what we consider diminished ovarian reserve. But a 0.9 is not a bad number, and I would really have and would want you to have a lot of optimism for your ability to get pregnant through this process. FSH is the hormone that your brain makes. The fewer eggs that you have, the less estrogen you make, and the less estrogen you make, the more your brain says we need more estrogen. And so how does it make more estrogen? It says develop more follicles. And how does it develop more follicles? FSH, follicle stimulating hormone. Brain tells the ovaries, make some more follicles, produce some more eggs, because that's where your estrogen comes from. So a 5.9 is pretty good. 0.9 on the AMH is not a terrible number. So again, please don't think that you're too far really behind the 8 ball. Let's see. My dear friend Eileen, on whom God smiles every single day. You guys, my AMH was 0.9 at one point, and I followed it starts with the egg protocol, and it raised it up to 2.26 after 4 to 5 months. There is hope, ladies. The book info works. Holy cow, Eileen, I did not realize that, but that is really extremely impressive, as are you, and as are the ovaries you brought to our broadcast today. So thank you, Eileen, for being here. As always, do you find people getting pregnant after HSG testing? And the answer to that is, oh yeah. There is definitely a documented improvement in the pregnancy rate in the 1 to 2 months after doing the HSG. Now, I will tell you, I perform HSGs here just about on a daily basis. It is one of the crampiest things that we do to people. I don't love how it makes people feel, but to be honest with you, we can do it pretty efficiently, pretty easily, and it's over with very quickly. And there is not only diagnostic significance to that, but yes, there is therapeutic significance to that as well. The 1 to 2 months after doing an HSG. And you imagine what's happening there is that it's kind of just clearing out some of the cellular debris that may be in the fallopian tubes that are trying to prevent sperm from being able to get through. So you're removing some roadblocks so that sperm find it easier to meet up with eggs. So yep, HSG has therapeutic value is the way I would say there. Bossy V, I like that name, Bossy V. I've done IUI and now in my second round. I am 36 years old. My husband is 38. When should we start to consider IVF? Hey, that's a really good question. The truth is, the data shows us that after 5 rounds of IUI, you are no more likely to get pregnant with IUI than you are with home intercourse. Now, my personal opinion is that 5 rounds of IUI is too much because it sucks the life out of you. You have such high hopes every time you go in. You're just expecting and hoping and thinking, this may be the month, for crying out loud, that it's going to work. and then you're waiting and you're waiting, and you go through the whole thing, and you get do the whole process. You've got your monitoring, and you get your sperm placed inside, and then you get a period, and it's like, oh, what a letdown. And the period is supposed to, is not supposed to be some constant reminder of how things didn't work. And I think it really kind of stinks. So to my mind, I think 3 cycles is plenty of IUI. Yeah, you could do an extra couple of them if you wanted to. IUI, to be honest, is very appropriate in a situation where IVF is going to cost you $20,000 or $30,000, because it is a much cheaper alternative that increases the probability of the right sperm being able to meet the right egg at the right time, because that's really the goal of the whole process, right? Well, in IVF, we're causing them to shake hands. We're introducing them one to one, as opposed to putting 10 or 20 million inside of the best swimmers and hoping they'll be able to get where they have to go if we give them a little head start. And that's what we're doing with an IUI. By the time you've done 3 cycles of IUI, you've probably already spent more than you're going to spend for a single cycle of IVF. And again, with IUI offering you anywhere from probably a 5 to a 9% chance of pregnancy per cycle, and IVF up to 60% chance of pregnancy per embryo, doesn't make sense to keep doing IUI. So some would even argue it's unethical to even offer IUI because IVF is so much more successful. But if you do one IUI and you get pregnant, well, then you're a hero. I mean, then everything worked out great. You spent way less money, way less effort, way less stress. And gosh, it happened the way it's supposed to. But after a few times there, Bossy V, I'd say, then think about stepping it up a little bit. So hopefully that helps. Are the prices, this comes from Unspoken Lyric, are the prices the same for someone using insurance? Again, I don't personally know everybody, I'm not the finance side of things, but everybody's insurance is different. And it has to do with your employer, not so much the insurance company, because I have Blue Cross, maybe you have Blue Cross, but our coverages may be completely different for what we're doing here. It really depends on your insurance and what they cover and what the deductible is and what the co-insurance and the co-pays are. In our portal, or rather in your portal, in the financial welcome packet, it talks about what are the questions that you need to ask of your insurance company to kind of really understand exactly what your benefits are as they pertain to fertility services. So, Unspoken Lyric, I like that name. Lola Babe 2000, do we provide hotels for patients who come from out of state? So yes, really at all of our locations, we have discount arrangements with different hotels, or with at least one hotel, sometimes more than that, who have specials they'll offer for our patients who are coming in from globally to be taken care of for IVF locally. And that holds true for Colorado, as well as for all the locations in New York. I'm still sitting here with my fingers crossed that Sarasota is going to be up and running very soon. My good friend Dr. Kondrup is the doctor there, who is a very, very nice man. If you haven't had the pleasure of meeting him and working with that really wonderful Sarasota staff, we're very excited about it opening. I'm told that it just has to do with getting some last minute permits and some things like that. So originally it was going to be July the 1st, then it was August the 1st, then it was mid-August. Anytime now, God willing, Sarasota is going to be online there. All right. Let's see what else. Oh, and actually, Be Positive Girl just asked any updates on Sarasota. See there? I read your mind. Does PGT testing trump embryo grading? This comes from Kay Stein. The answer is yes. So remember that embryo grading was originally developed so that could an embryologist look through a microscope and look at an embryo and make some assessments about what they see and determine based on those assessments whether that embryo was chromosomally normal. Well, as it turns out, the answer is no. So it's a beauty contest. You can look at it and you can say, okay, this is a very beautiful embryo, but you may have a very beautiful embryo that has complex chromosomal abnormalities. Or you may have a very ugly or poorly graded embryo that is your only chromosomally normal embryo in the bunch. So once you have an embryo that says it is euploid, that it is 46 chromosomes, either XX or XY, the grading at that point doesn't matter anymore. Euploid is euploid. Euploid is at the top of the totem pole. Good question there, Kay Stein. Oh, and actually, here's a little follow-up information. I have 10 embryos frozen and biopsied 8 of them for testing. The grades were not the greatest, and I'm worried. Well, you know, the whole process, my friend, certainly creates worry and anxiety, and that is one of the things that your whole community is here for. We stand with you during this, going back to that crappy roller coaster ride. Yep, we are all here and certainly all understand that anxiety. But if you were tested, if you tested your embryos and it says euploid, you're at the top of the heap. That is the top of the totem pole. Way more important than grading. Let's see what we got here. Oh, Away Goes Paige is coming to see us tomorrow in Colorado. I guess I should say Here Comes Paige instead of Away Goes Paige, but look forward to seeing you. Can a hysteroscopy diagnose endometriosis? No, hysteroscopy. Hystero means uterus. Scope means to look inside. So hysteroscopy is to look inside the uterine cavity, and it can diagnose things like polyps, like scar tissue, like bands of muscle, like balls of muscle, like fibroids. That's what a hysteroscopy is for. Endometriosis is the process where that lining of the uterus that we would see when we look with the camera inside the uterine cavity, that lining, instead of sloughing off like it does when you have a period, instead works its way up inside and implants within the pelvis. That requires laparoscopy. Laparoscopy is a surgery where we place a little camera in through your belly button and look around, see what we can see. If there is endometriosis, we try to treat it. We used to just cauterize or try to burn away endometriosis, but what we know now is the endometriosis that we see is usually just the tip of the iceberg, which means that the best treatment for it is to excise it, is to cut that little piece of tissue out from the inside, which is what we do with laparoscopy. So laparoscopy is for endometriosis. Hysteroscopy is for looking inside the uterine cavity. This comes from Sammy Joe 22. I got my PGT results on my 2 embryos from the last retrieval, and both were abnormal. Well, I am disappointed to hear that, my friend. Do I need to do a consult before another retrieval? No, you can really just tell the staff that you would like to proceed with another retrieval, but sometimes it may make sense to have a consult and talk to one of us to look at your protocol and see if there's something that we can tweak with it to try to improve your outcomes. Because you did one retrieval and we got some data, right? We got some information. We learned from you how your body is going to respond to those medications. And as a result, you got 2 blastocysts that were able to be tested. Well, sometimes we can take that information and learn from it and know how to give you a little tune-up to try to get you a better response since we got that information. So, you know, I'd say I would recommend a consult if you can, but if you can't or you don't want to, you simply have to let the team know that you'd like to proceed with another cycle, and then you'll be using that same protocol. Always Forever Love coming to see us in October. That is a wonderful thing. Glad to hear it. Cherry 0827. I have 3 kids and found out I have endometriosis and I don't have my tubes. Can I do IVF? The answer is, oh yeah. So if you don't have tubes, IVF is the way that you will get pregnant. Now, there are some people with endometriosis who have no issues getting pregnant or no issues with IVF at all. There are some people with endometriosis who can have just terrible endometriosis and have no symptoms from it at all, whereas some people with very mild or minimal endometriosis have very significant symptoms. But yes, absolutely, IVF is the treatment of choice, is the treatment for you, because that's how we can get you pregnant without needing fallopian tubes. Sometimes what we'll do is we'll suppress the endometriosis for 60 days. We can do that with medications, and that can improve your outcomes. But this is all worthy of a conversation here, my friend. We've got about 5 more minutes on Fertility with Fink and Friends. So let's see what else we can get to over here. Tamara on the Facebook side is asking, what is IVIG and who should look into this add-on? IVIG is intravenous immune globulin. IVIG, immune globulin, and it's kind of the biggest gun we have as, call it an anti-inflammatory. So it's something we think of for folks with otherwise unexplained repeated implantation failure. For reasons that we don't understand, we will presume that it has something to do with the immune system. Biggest gun we have to try to suppress that immune response that can be keeping you from getting pregnant. That's the best indication for it, but it's expensive. I wish it was something that everybody had the ability to use, but it can be very pricey, and that's why we're very selective about the people whom we recommend it for. BJ Pumping asks, what is baseline? Baseline means when you're at the start of the cycle, we expect that your ovaries are going to be looking quiet and that your hormone levels will be sort of at the baseline or the basement level, because as the cycle goes on, the lining starts to get thicker and the hormone levels start to go up. So baseline is the beginning of a cycle, whether it is an embryo transfer cycle or an IVF cycle. Good question there. Brittany's asking, had my first IUI today. All 3 follicles were on the right side and I'm cramping on the right side. Any reason why? Well, it may be because you're ovulating. So when your ovary is releasing the egg, you may be feeling that. There's a term for that. It's called Mittelschmerz, which doesn't necessarily mean that you're feeling the ovulation itself, but sometimes that pain can arise in a day or 2 or sometimes even 3 after the egg is released. But my guess is that you're probably feeling ovaries are very active things. They're always kind of doing something. So my suspicion is you're feeling your follicles there trying to get you pregnant, which sounds like a good idea to me. Kira is asking about ovarian rejuvenation, and that's something that's called intra-ovarian PRP, platelet-rich plasma, and that's where we take a tube of your blood and separate out your body's tissue components, your growth factors, your healing components, and can place them directly back into the ovaries, which can have some benefit on egg quality and sometimes even potentially on ovarian reserve. So it's still considered experimental. There isn't a lot of data on what the optimum timing of treatment is, how many treatments are necessary in what circumstance and what situation. So we kind of guess at that a little bit, but that's what ovarian rejuvenation is, intra-ovarian PRP. I think we may have time for one more here. Meow, meow, meow. What do you think about slow rise HCG following a day 5 blast transfer? My first beta was 157 and the second's 201. We suspect that most normal embryos, 2/3 of normal embryos, will double that HCG in 48 hours, but that means 1/3 of them don't. These are all highly desired pregnancies, so I never suggest you throw in that towel prematurely, but it does mean we want to know for sure that the pregnancy is in the uterus, not in the fallopian tube, because an ectopic pregnancy is potentially a life-threatening situation. So meow, 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 meow. That's what we're looking at. Guys, it is always such a pleasure to be with you here, and I really appreciate you taking your valuable time to join me. Please keep an eye on my Instagram. This week, I just decided I would tell some bad jokes, some dad jokes, because I'm always being blamed for my sense of humor over here. So I hope you'll get some enjoyment out of that. Remember what I always say, that fertility and infertility is not the novel written about you. It ain't your book. It is merely a chapter. And what we are here to do is to help you to rewrite that chapter. So until next Tuesday, God bless all of you. Thanks again for being here. And I wish you a very wonderful week. Good night.